This program is brought to you by Emory University.
Good morning and welcome to Heart and Vascular Grand Rounds. This morning the talk will be on beating the odds, and it's not a talk on the Falcons being in the Super Bowl. Go Falcons. No, Dr. Divya Gupta, who's an advanced heart failure and transplant cardiologist with our program, will be giving a talk about the Emory experience in heart failure. Divya did her undergraduate work at Georgia Tech and has an engineering background. She did her training in medicine and cardiology and advanced heart failure here and has really done a fantastic job clinically and with clinical research. And within the last 2 years has been working on a project across Emory Healthcare that she's been the physician lead on, and has really done a fantastic job in working with the various disciplines that are involved with managing our patients with heart failure. Divya?
Thank you, Dr. Smith, and good morning, everyone. Thank you for coming. I wanted to take this opportunity to share with all of you a little bit about the Emory experience with heart failure, how it's managed throughout our system, but more so the work we've been doing with regards to improving the care that we provide for our patients throughout the system, and hoping that that translates into better outcomes for all of our patients. I have no relevant financial disclosures except for the fact that I am employed by Emory, just like everybody else. We're going to talk a little bit about epidemiology, and then I'll go into the Emory experience with heart failure, and then the work that we've done with trying to decrease length of stay as well as readmission rates throughout our system, and future strategies that I would like to see us possibly employ to improve on a lot of that. There are over 1 million people that are admitted annually in the United States for heart failure with a primary diagnosis of heart failure. Almost 4 million people carry a primary or secondary diagnosis of heart failure during their admission. This is costing our country over $17 billion a year in healthcare expenditures. Now, what's Emory's contribution to all of this? Well, in fiscal year 2016, we had almost 2,600 encounters for heart failure throughout our Emory system, and that equates to a little over 2,100 discrete patients. Midtown was the largest contributor with almost 1,000 encounters. Next came Emory Clifton Campus with almost 850 encounters. Next, St. Joseph's with 600, and then Johns Creek with almost 200 encounters. The burden of heart failure, as we all know, a great deal of it is during the hospitalization. It's not necessarily devices that we use during that hospitalization or the medications that we use. Our medications for managing heart failure are really on the cheaper side compared to a lot of specialties. But really the great burden with the cost of heart failure is the hospitalization itself, so the amount of time that patients spend in the hospital. And this also carries with it a lot of medical implications. As we all are aware, the longer that a patient is in a hospital, the more likely they are to suffer from healthcare-associated infections or complications. But our patients are pretty sick, and a lot of times they do require an extensive amount of time in the hospital, sometimes because they have an extensive amount of edema. It's not unheard of for someone on our service to be diuresed 100 pounds of fluid during their hospitalization. These are very complex patients that have multiple comorbidities that also need to be managed during that time period. The issue of renal impairment can really delay discharge for some of these patients and giving them the appropriate treatment during their hospitalization. There's also a lot of social issues that have to be dealt with to try and make sure the patient has a successful discharge home, trying to make sure they're able to get their medications, make it to their hospital appointments, make sure they have the appropriate social support where they live. Readmission also carries with it a heavy burden for the individual. With their first hospitalization, a patient now has a 30-day mortality of 12%. They have a 1-year mortality of 34%. So that means for every patient that's in the hospital right now with heart failure, if it's their first hospitalization, 1 in 3 of them will be dead within the next year, which to me is pretty staggering. And I think we forget that a lot of times. With each readmission, that mortality rate goes up by another 2%. So imagine that a patient comes in another 4 or 5 times within the year for heart failure, their mortality has just gone up by another 10%. So their 1-year mortality is almost 50% at this time. It doesn't matter what kind of heart failure we're talking about. It could be heart failure with reduced EF, where we actually have medical management strategies to try and optimize how the patient does with heart failure, try to help them feel better. It could be heart failure with preserved EF, where despite our best efforts, we've actually made no lengths in trying to really improve these outcomes. We've had minimal success in improving mortality. For both types of heart failure, the mortality rate is exactly the same. Survival is not any different, despite what type of heart failure these patients have. Interestingly, that also translates into lengths of stay that are approximately the same for both types of heart failure, as well as readmission rates that are the same for both types of heart failure. So it's not that heart failure with preserved EF is a more benign type of disease process. Both have the exact same mortality and issues with readmissions and length of stay. Both need to be treated with the same amount of acuity. Interestingly, it's really important that we try to manage these patients right the first time. The longer a patient's length of stay, the less likely they are to get readmitted, most likely because we actually do it right the first time. We're able to get off all the fluid that we possibly can to really decongest the patient. We're trying to manage all their comorbid conditions. And because of that, we're actually able to reduce these readmission rates. Now, that doesn't mean we keep the patient in the hospital for an extended period of time, obviously. What we have to do is really find the right balance between that length of stay and the readmission rates so that we can minimize our length of stay as much as possible to reduce our readmission rates as much as possible and really try to find that sweet spot. Those are chocolate chunks, if you can't tell. Now I want to give you a little bit of insight into what this translates into for the Emory system. And so I got involved with this, as Dr. Smith mentioned, through the value acceleration process, which is a project to try and improve our process for taking care of patients by standardizing care and increasing our efficiency, all in the hopes of trying to improve the care we provide our patients, leading to improved outcomes. We gathered a team of, I think, almost 30 plus people at one point, with physicians, nurses, APPs, dietitians, social workers, nutritionists, care coordinators, representatives from home health and infusion companies to really bring together all the aspects that are involved in managing heart failure patients. And we started by looking through the data to figure out exactly who is caring for these patients and where can we make the biggest impact. I was quite surprised to actually find out that in the Emory system, the majority of heart failure patients are admitted to the hospital medicine service. I was pretty sure that almost all of cardiology took care of all of heart failure at this hospital, and every now and then we admitted to hospital medicine. Surprisingly, 39% of patients admitted to the Emory system are admitted to a hospital medicine service. 36% come to cardiology, another 25% go to various other services such as family medicine and nephrology. The majority of these patients are a little bit on the older side. Patients between the ages of 65, and the oldest patient with heart failure in fiscal year 2016 was 103, equated 60% of the population of heart failure in the Emory system. They also accounted for about 54.4% of the readmissions, with about 21% of these patients being over the age of 80. That's 21%, of readmissions being over the age of 80. We do see a fair number of younger patients, 41% almost, who do have a slightly higher than expected readmission rate of 45.6%. What I mean by that is, for the population that you would see, you would expect maybe a lower readmission rate in proportion. However, they are slightly more uninsured patients in this population. They are younger. They may not have gotten any sort of coverage, and for that reason, they may have a harder time getting their medications, getting follow-up appointments as needed, and maybe having issues with readmissions for that purpose. Also, the younger patients more likely have a more severe heart failure, so maybe they're more stage C, stage D on presentation versus presenting earlier in the course. In comparison, nationally, readmission rates are approximately 25%. That's 30-day all-cause readmissions. 37% of these are for decompensated heart failure. So patients discharged after a heart failure admission and come back in with heart failure again. That means the other 63% of readmissions, more than half, are due to other comorbid conditions or some sort of hospital-associated complication. So most of these patients are coming back not because of heart failure, because of other associated problems. At over 6 months, over half of these patients are going to get readmitted. So how does Emory compare? Surprisingly, or not so surprisingly maybe, we do pretty well. Our 30-day all-cause readmission for fiscal year 2016 is under 17%. The highest contributor to this is Clifton Campus with 17.95%. Next came St. Joseph's Hospital with 17.6%, then Midtown, and then Johns Creek. So, I can throw a bunch of numbers at you, but how does that mean we compare to the rest of the nation? So Vizient is a hospital service or healthcare service that provides data and data extraction for a majority of hospitals throughout the United States, and they rank their hospitals in the top 20. So if we compared ourselves in fiscal year 2016 to the top 20 institutions of 2015, through the Vizient Top 20 Institutions, we actually find that we rank 2, 3, 4, and 5, our hospitals, which is not so bad. Now, U.S. News, which is probably a comparator that most of us are a little more familiar with, you will see comparing our FY 2016 readmission rates, 30-day all-cause readmission rates, to the national readmission rates using U.S. News Top 20 Institutions, we actually rank 2, 4, 7, and 8. So despite which system you use, we are still in the top 10%, meaning we have the lowest readmission rates in the top 10%, top 10 institutions, not even 10%, my apologies, top 10 institutions with regards to our readmission rates, which is really good. But good is never good enough for Emory. So we're going to keep pushing that envelope because our goal is to continue to improve the outcomes for our patients and try to improve the quality of care that we can provide. The first thing we decided to look at was decreasing the length of stay for our patients, really trying to optimize and standardize care. What's the biggest reason patients come into the hospital? For the most part, everyone is warm and wet, and our biggest goals are diuresis, diuresis, diuresis. We really have to get that fluid off of patients. And the place to really start doing that is really the point of first contact, which for the majority of our patients is the emergency room. And one thing we noted, more so anecdotally, because we really don't have the data to show this, was that based on our experience, very often patients do not receive the appropriate diuretic dose at that first point of contact in the emergency room. And so we really needed to work on educating and optimizing the orders that these physicians can use in order to make sure patients really get appropriate diuretic dosing from that first point of contact. So what is that appropriate dose? Well, as we all know, in heart failure patients, the dose response curve for diuretics is significantly diminished. It takes a much higher dose of diuretic to get the same response as it would in any other individual, and the maximum response is much lower compared to a normal individual. Therefore, our patients require significantly higher doses than you might expect for anyone else. The dose trial also helped us understand exactly what that dose should be, and using the higher dose of 2.5 times their home dose of diuretic in IV form really showed that there was significant improvement in dyspnea for the patients that received that higher dose, as well as, which translated also by increased volume loss seen as significant weight change over that 72-hour period. With that, unfortunately, did come a slight increase in creatinine that was seen. However, that increase in creatinine is pretty transient, not only shown in the dose trial, but in load, as well as in CARES trials. So this transient worsening renal failure that we see really translates during their admission into what I'd like to call permissive hypercreatininemia. These small increases in creatinine really shouldn't bother us. As long as the patient continues to diurese, we continue to diurese them. Personally, I don't feel it's necessary to even involve nephrology at that point, because the issue is that the patient just has to get the volume off. They may have small changes in their creatinine, but again, that's going to resolve upon discharge within 60 to 90 days based on several trials. So the goal should really be to decongest the patient. Studies have also shown that if a patient is discharged home with congestion, their survival curves are significantly reduced. They do much worse despite what their renal function is. And so really decongesting the patient, even if they have issues with worsening renal function, is the most important part of their admission. Again, that transient worsening renal function actually equates to survival. That's the same as patients that have no issue with their renal function during their admission. So point again to keep diuresing as best as you can despite small increases in creatinine. The other thing we really need to look at is making sure we efficiently use the time during this hospitalization to deduce exactly what the inciting issue was that caused the decompensation. Many people really like to point to the extra French fry or the bite of pizza someone took, but interestingly, there's very often an organic cardiac etiology for the decompensation. And so that has to be figured out during that hospitalization. There may also be multiple other comorbid conditions that these patients suffer from that have to be assessed and managed to make sure that they are not the cause of decompensation, that they are not an issue during the admission, that they're well managed so they don't become a problem after discharge. So these are very complex patients. It's not just about diuresis, although I did make it sound that way in the beginning, but it's really about managing all of these medical problems that these patients have to make sure they have the best outcome. So again, efficiency is key, and a lot of these patients really do need to get a social work consult early. Several of our hospitals, St. Joseph's and Emory Midtown, actually have care coordination teams to help and assist with this. They meet with the patients early, typically on day 1 or day 2 of their hospitalization. They do an assessment based on socioeconomic needs, the patient's ability to get their medications, the ability to make their clinic visits. Health literacy is also an important part of their intake. And they assist early on in trying to make sure we meet and tackle all of these barriers prior to discharge so there are no setbacks when it comes time for the patient to go home and can stay home and make it to their appointment successfully. Nutrition consultation is also very important during a patient's hospitalization. We have to make sure, I don't think we can ever educate these patients enough on the importance of staying away from excessive amounts of sodium and watching their fluid intake. Sodium is ubiquitous in our diets here. Everything is preserved in salt, and it really is a difficult way to live, especially when everyone else around you is enjoying chicken wings when the Falcons are playing. So you have to, I think, education on nutrition consistently when the patient's coming in is really important. Physical therapy can also be very helpful. Many of these patients have been debilitated at home, gaining fluid, not really doing a whole lot, and then they come into the hospital, and we again keep them here, we're diuresing them, they don't do a whole lot. Having physical therapy involved early, making sure these patients get the appropriate assessment. So if there is a need for subacute rehab, that can be known early on to make sure those sorts of referrals are placed. But also these patients are then given instructions on mobility, et cetera, during the hospitalization so they don't become debilitated while undergoing their treatment. Any patient taking over 10 medications should really be considered for a pharmacy consult. Polypharmacy is a big issue with a lot of heart failure patients, especially with all of their comorbid conditions. And so we have to make sure that the patient understands all of their medications, and those that really aren't necessary maybe can get teased out a little bit. And so we have to really work to see if pharmacy can help us do that. Again, like I said, treating the entire patient, looking at all the comorbid conditions. I can never reiterate enough how much education and re-education in heart failure is important, and making sure patients understand self-management strategies. This is not only a job for the physicians, but for the nursing staff as well. We have to explain to the patient the importance of daily weights and vital signs, medication compliance and the importance of their medications, doubling their diuretic if they have an increase in weight, how to do that if you feel they have the ability to do that. And if they can't do that, making sure that they understand who they should contact. What's the number for the office? How are they going to get in touch with us if they do start developing symptoms of heart failure, and helping them recognize what their symptoms of heart failure actually are. So by taking all of these ideas into account, in order to reduce length of stay, we first started by updating the power plans and the order sets for the emergency room. Again, the biggest thing that we did there was really update the amount of diuretics these patients should get. Initially, the ER order set had 20 milligrams as the standard for, 20 milligrams of IV Lasix as the standard for diuretic dosing for any patient coming in with dyspnea or heart failure. So we made sure to give them a little blurb stating that really the appropriate dose is 2.5 times their home dose of diuretic in IV form. We then gave them equivalency for PO diuretics to IV, so they can now have a better understanding of appropriate dosing. We also, given that HMS does admit most of the heart failure patients seen throughout the Emory system, we actually collaborated with the hospital medicine service and had them create a heart failure order set specific to them. They felt that the current cardiology order set really didn't meet all of their needs, so they never used it. Their patients are typically older. More often, I think they see some HFpEF. So they felt like none of the comorbid conditions that these patients have was actually dealt with in the cardiology heart failure order set. So with their assistance, we created the heart failure portion of the order set. We actually provided some educational sessions for them as well. They then collaborated to create the diabetes management, COPD management, any other portion, comorbid conditions that they felt like were often seen in the heart failure population. The other thing that we did was add orders to help make sure that consults for social work, physical therapy, nutrition were automatic, so you actually have to uncheck them if you don't want them. That way these patients can be assessed by social work and nutrition at time of admission. We also updated evaluations for possible reasons for decompensation, checking basic things like TSH, anemia, CBCs on a regular basis. That wasn't always happening. So making sure that those basic reasons for decompensation were also being assessed at time of admission. While we were at it, we updated the cardiology heart failure order sets. Medications like Nipride were still on our old order sets, so hopefully you're not seeing that on there anymore, since we do not even carry it at our system. And how does that translate? Well, this is looking at length of stay index, which is our average length of stay divided by the UHC average length of stay. And as you can see, over the last 3 years, we've actually made significant improvements. That index used to be at 1.2 and now is all the way down to 1. So we used to have average length of stays much higher than the average, and now we've come down to those that are equal to the UHC average length of stay. Which makes these numbers even more interesting is that over this 3-year period, the UHC average length of stay has actually decreased. So not only did we meet that demand, but we surpassed it if you think about it, because we were far above what was expected, and we've come all the way down to at least meet those expectations, despite the fact that those numbers on an average UHC standpoint have been going down. And currently, that average length of stay is just over 5 days. What has our work been with regards to reducing readmissions? And this really was, I like to call it a lesson in diagnosis. Again, because we have 4 very different hospitals with 4 very different patient populations. As you know, Emory Hospital sees a lot of end-stage heart failure. It is a referral center for heart transplant. Midtown has a very high percent of underprivileged patients with poor socioeconomic support and low health literacy. It's also still a very ill population, mostly because they do have issues with making it to appointments a lot of times, maybe getting their medications, and they still see end-stage heart failure. It's just that they don't have the ability to get some of the advanced care that we can provide. St. Joseph's Hospital is also a referral center for heart transplant, sees a lot of end-stage heart failure, and many of these patients are actually followed by non-Emory cardiology. Johns Creek also has many patients that are followed by non-Emory cardiology. And at the time that we started this project, there was actually no heart failure clinic at this hospital. It was the one hospital where we actually had no heart failure presence, and there were no physician consultative services. Now, that being said, I don't want to take credit away from Anita Rich, who did a fantastic job out there and was the lone person representing heart failure for quite some time and trying to take care of these patients in the hospital. So in order to try to figure out how best to reduce readmissions, given that we have such diverse populations throughout our hospital system, we first went to the data. And so a study from 2010 looked at how we target the preventable readmission. And readmissions really are multifactorial. Again, there's issues of compliance with patients, mostly because of low health literacy or education. There's a lack of knowledge about self-care throughout the system. There's inadequate discharge preparation education that can take place. A lot of times there isn't great communication between the acute care physician and the post-acute care provider, so that transition from hospital to clinic does not happen as smoothly as it should. One of the biggest issues that we see with heart failure and readmissions is delayed discharge follow-up. So patients not being seen in a timely manner after their discharge is a big reason for readmissions. Also, the lack of management of comorbid conditions during their hospitalization. Again, like I said earlier, 63% of rehospitalizations are because of other etiologies, not heart failure, comorbid conditions or hospital complications. And so making sure, the lack of management of those conditions leads to these preventable readmissions. How do we tackle this? It really does require a multidisciplinary approach, and never has it been more true that we're all in this together. It's not only up to the clinicians for us to educate our patients on a regular basis, whether it be in clinic or in the hospital, but it really does take an entire team. We need the nursing staff to be well educated so that they can continue to teach the patient about what they're doing when they're measuring I's and O's for the patient during the hospitalization. Why is that important? Why do we check their weights every day? What a patient is supposed to do if they start to feel symptoms of heart failure or have an increase in weight. The pharmacist can assist in educating patients on the importance of their heart failure medications, how best to take them, and also, again, help tease out maybe medications that they really don't have to have and try and prevent polypharmacy. A heart failure educator, navigator, again, can help bring this all together. Guidelines actually state a patient should have 1 to 2 hours of one-on-one individualized heart failure education, which is difficult for any one of us to do for all of our patients. Think about all the people we take care of. But having someone dedicated to that task would be ideal. Also, a navigator trying to help this patient get through the system. I, as a physician who works here, have a difficult time sometimes navigating the system. Can't imagine what a patient with a serious illness is having to deal with. Care coordinators can also help assist with a lot of management of these appointments and making sure that basic social needs are met. The social worker can assist with that as well. And the nutritionist, as I said, I feel like we can never educate our patients enough on the importance of dietary compliance. So everyone, I think, is familiar with Get With The Guidelines. There are different types of Get With The Guidelines. There's one specific to heart failure. And we would all assume that if we follow guideline-based medical therapy for managing our patients, that really would be the best way of keeping somebody out of the hospital. Well, out of curiosity, Get With The Guidelines decided to look at this. And so what they assessed was institutions between the years of 2009 and 2012 that were involved with the Get With The Guidelines project, and they looked at those that initiated guideline-directed medical therapy prior to discharge, addressed management of comorbid conditions, whether or not patients got their device implantation when appropriate, patient education on compliance and disease process, as well as medication discharge instructions, educating patients on daily weight monitoring, and referral to a heart failure disease management program when appropriate. So they only looked at institutions that were at the highest level of accommodating all of these requirements with Get With The Guidelines. Unfortunately, following the guidelines isn't enough to try and prevent readmissions. Between the years 2009 and 2012, again, you can see there was really no difference in readmission rates. As you can see here, these are 2009 readmissions, these are 2012, and they're all still clustered around the same place. So despite institutions following the guidelines for heart failure management, that really isn't how we try and reduce readmissions. Yes, it is important to make sure we provide quality care for taking care of our patients, but it doesn't necessarily keep the patients out of the hospital. So the American College of Cardiology came up with 10 key practices for trying to, again, have a successful discharge home and keep patients out of the hospital. So one of the big things they looked at was making sure that there was some sort of quality improvement team, which is kind of what our value acceleration process is, in trying to look at reducing readmissions and monitoring those 30-day readmission rates. Another key component of this was making sure that patients follow up after a heart failure discharge within 7 days of that discharge. And this is key, and it's going to keep coming back. Another big part of it was medication management, making sure that patients understand the importance of their medication, that a pharmacist actually performs medication reconciliation and medication history taking, as well as providing the education on the best way for a patient to take their medications and the importance of their medications. Also making sure that at discharge and follow-up, there's clear communication between the discharging facility and the follow-up physician within 48 hours of that discharge, because remember, that physician at follow-up is going to see the patients within 7 days. So making sure you communicate with that physician in a timely manner so they have the information they need about the patient's admission. Making sure that the patient understands who to contact if they have any sort of an issue prior to that follow-up, and making sure that the patient has their appointment in hand prior to discharge. All of these are key in trying to make sure that the patient can stay out of the hospital. And they actually assessed how important are these key practices. Well, the more of these practices that an institution implemented, the lower their readmission rates, as you can see here. At the point of after implementation of 8 key practices, their readmission rates fall significantly. And so the more of these practices that we can put into place, the better our patients are going to do, and the more successful they're going to be with staying out of the hospital. They then translated this into the concept of hospital to home, in which they summed it up into 3 key components. So CU in 7, making sure patients are seen 7 days, within 7 days of discharge after their heart failure admission. Making sure patients understand the importance of all of their heart failure medications, and making sure the signs and patient understands what their signs and symptoms of decompensated heart failure are, so that they know when to contact somebody or what to do about it if they have these issues. Now, there are some patient factors, but again, the importance of having a navigator or social worker see these patients in the hospital is to try and overcome these patient factors. So a patient's ability to get to an appointment can sometimes be an issue with having success, but if a social worker or care coordinator is involved early, hopefully we can overcome that challenge. And making sure patients are familiar with their medications and have access to their medications, again, are very important when working with our pharmacists, our care coordinators, and our social workers. So very important to mind that gap. The biggest thing that most guidelines actually tell us now is that the best way to try and reduce readmissions is to make sure that patients are seen within 7 days after discharge. The longer that time period, the more likely that patient's going to have a readmission, because maybe they're not understanding their medications correctly, maybe they're having issues with diuresing appropriately with their home diuretic regimen. That 7-day window is very important to making sure that these patients don't fall through the crack or the gap, if you will. An unfortunate fact that I do have to mention is that heart failure is a terminal illness, and we can't forget that. There is a 5-year, 50% mortality attached to this diagnosis, and despite our best efforts, we cannot reduce all readmissions, partly because one of the signs of approaching stage D heart failure is having readmissions despite compliance. And so no matter what we do, it's going to be impossible to get rid of all readmissions completely. Again, despite our best efforts, we were making some progress with regards to mortality and heart failure. However, the last few years, mortality rates have gone up significantly, as you can see here from 2012, and this goes to 2014. This is data from the CDC. Most likely, this is due to the fact that we do have an older population of patients. Heart failure is a disease of the elderly, and it's possible that these are patients that we're now seeing an increase in mortality in. But the mortality rate has gone up for this disease, unfortunately. The more comorbid condition a patient has, the more likely they are to be readmitted into the hospital. I think it just makes sense. You have so many medical problems, it's going to be difficult to stay out of the hospital. And so this also relates to higher mortality for individuals. Palliative care is a key part of heart failure management. Again, heart failure is a terminal illness. We have to remember to consult palliative care when it does seem appropriate. And we work together with them very strongly. According to British Medical Journal, really you should have palliative care involved from the very beginning. They not only provide palliative care and end-of-life services, but they can really assist in supportive care and making sure that symptom management and quality of life are also addressed during this time when patients are being assessed for their heart failure. As you can see here, this is a patient's receiving traditional care with their heart failure, and palliative care really can be involved from the beginning to make sure we address all of the patient needs. Once a patient gets to a point where their mortality is significantly higher and they may be nearing pump failure, that's when palliative care can start taking over, especially if there are no options for advanced heart failure. And they can start providing the essential care for the individual. The biggest issue with heart failure, as all our curves show, unlike most terminal illnesses where patients are doing fine and then they fall off a cliff, we really just have a lot of valleys. And so it becomes difficult when to tell a patient this is really nearing the end. But palliative care is something that can be involved from the beginning, not just providing those palliative services, but supportive care throughout the patient's course of their disease. Again, like I stated before, they don't provide just end-of-life care and hospice care. They provide a lot of improvements in quality of life, symptom management, advanced care planning, and they really assist us when it comes to shared decision-making. So much of what we do in medicine, especially when patients are nearing end stage of heart failure, is very high risk, and despite what we do, it's not necessarily an end-all be-all treatment. There are still complications associated with the management of patients of end-stage heart failure, whether it be transplant or LVAD therapy. And for that reason, we have to make sure that all goals of care for the patient are met during this entire process. We don't want to put someone through something that really doesn't meet what their goals for their life expectancy and their quality of life are. So when should we consider palliative care? Well, American College of Cardiology has actually put out with a recommendation list, a list of when to consider palliative care for individuals with heart failure. And what they state is anyone that's had greater than or equal to 1 readmission over the last year, anyone that's had recurrent ICD shocks or refractory angina, so things that kind of equate to having worse heart failure or worse cardiac conditions. Also, anyone with multiple debilitating comorbid conditions, including older age, those over the age of 80, lower renal function with GFRs less than 45, hypotension, hyponatremia. Also, anyone dealing with anxiety or depression that could affect their quality of life or ability to manage their illness should really get assistance with supportive or palliative care. And as I'm sure everyone understands, patients with approaching stage D heart failure should also be considered. We have actually incorporated palliative care into our management, into our evaluation of patients for advanced therapies, mostly because anyone that is seeking advanced therapies clearly has severe end-stage heart failure. If you have severe end-stage heart failure, clearly your prognosis is poor. A lot of times patients don't actually understand that. And despite getting an advanced therapy, your prognosis afterwards isn't always completely normal, and you may be fraught with a lot of complications afterwards. And so trying to make sure that expectations are met and managed correctly is a big part of having palliative care involved with all of our management of heart failure patients. So who is actually the best at trying to figure out who's approaching stage D or end-of-life care? Well, my friend Andreas Kalogeropoulos, I got it right, actually helped us assess that. He did a study looking at patients followed in our heart failure clinic and had about 500 patients with ejection fractions less than 40%, so these are all patients with heart failure reduced EF, and applied the European Society of Cardiology criteria for stage D heart failure and compared that to when the physician thought the patients actually had stage D heart failure. And to no one's surprise, I'm guessing, physicians actually did a better job at assessing when a patient was nearing end-stage heart failure than criteria that would be applied to try and determine that. So we as clinicians are sometimes the best at understanding when a patient is nearing end-stage heart failure and when we should possibly consult palliative care for our patients. So Dr. Butler, even though he wasn't here, published a study looking at our ability to actually even do something as basic as get advanced directions on patients with heart failure. He looked at patients at Clifton campus and at Midtown over a 3-year period and looked to see what percentage of these patients actually had advanced directives. I believe there were almost 5,000 patients that he looked at. And through this, we found that despite heart failure being a terminal illness, less than 20% of these patients had any sort of advanced directive. Not even talking about a palliative care consult or supportive care consult. This is just looking at whether or not a patient had advanced directives, directing us on how they wanted the end of their life to go. So less than 20% of patients even had that. So we did not do a great job at that. That being said, towards the end of that 3-year study period, there were more advanced directives that were seen. So we did start doing a slightly better job. But again, just less than 20%. Recently at the Heart Failure Society of America, 2 abstracts looking at palliative care were presented. One was called the SWAP-HF study, and this looked at about 50 patients with heart failure. Half of them received usual care. The other half were seen by a social worker to assess the patient's expectations with regards to their lifespan with heart failure and how they thought they were doing. Now, despite the fact that most of these patients were stated by their physicians to likely live less than a year, the majority of these patients thought they had 5, sometimes 10 years of life left ahead of them. And by having a social worker see these patients for palliative care routinely, goals of care were actually able to be addressed, and a better understanding of what their prognosis was actually found to occur with the patients. The PAL-HF trial came out of Duke and was also presented at the Heart Failure Society of America, and this looked at about 150 patients. Half of them received usual care. The other half got palliative care consultation by a nurse practitioner routinely. And with this, we actually found that patients that got routine palliative care had significant improvements in their quality of life and their symptom management. So again, palliative care is important not just for the end of our patients, but also throughout the duration of their heart failure course, because they really do help improve symptom management and quality of life, as well as manage expectations for what this patient is going to have to go through. So putting that all together, we then had to come up with plans of action that were not only individualized for each hospital, but then possibly even overrides the entire institution. So we started with Johns Creek. One of the things, again, was that Johns Creek didn't actually have a heart failure clinic. So we were able to create a heart failure clinic, albeit it is a small clinic. It currently runs at half day a week. The biggest purpose of this, again, is to try to close that gap and make sure patients discharged are seen within that 7-day window. Dr. Anand Shah, who is a heart failure board certified cardiologist, is overseeing that clinic along with Anita Rich. They also provide inpatient consultative services over there, which were not happening previously. Emory St. Joseph's Hospital has the majority of their heart failure patients admitted to hospital medicine services. We increased the amount of collaboration between St. Joseph's Hospital with hospital medicine service so that heart failure now consults on every admission for heart failure throughout the hospital. And so the hope is by doing this, we can really make that connection with those patients and provide early follow-up again in clinic over there so that heart failure is managed appropriately and possibly even patients that are nearing C state or C stage D can be caught earlier rather than later. At Midtown Hospital, the care coordination team has been working aggressively to really make early interventions during the admission with regards to socioeconomic barriers to successful discharge. They also provide close phone call follow-up with these patients. They actually call the patient on day of discharge, about 2 days after discharge, sometimes 2 to 4 phone calls within a week before they actually see the patient. They address a lot of questions these patients have, and they let us know if there's any barriers or issues with their medications or problems they might be having upon discharge. The other thing we implemented at Midtown was an outpatient Lasix in the COA. So patients that we see in heart failure clinic, if we find that they are somewhat volume up, instead of just having to admit them to the hospital, we actually have an outpatient ability to give Lasix to these patients in the COA over there. This has been very successful in multiple patients who have had many readmissions beforehand. Some of our patients are savvy enough, they can call us and tell us, look, I really think I need some IV Lasix. They can sometimes even come 2 or 3 days in a row to get that IV Lasix to stay out of the hospital. We just, they can do point of care testing for labs over there. Makes it very simple for us and for the patient. They like it better because they don't have to be in the hospital. We did the same sort of thing at Clifton campus by providing Lasix in the outpatient cath lab over here. So we see a patient in heart failure clinic, we can then send them down to the outpatient cath lab if we feel like they need a big dose of IV Lasix. Sometimes giving them that boost with the IV Lasix might actually help their oral diuretic work better. We'll bump up their oral diuretic for a couple of days and have them call us back to make sure they're responding appropriately after receiving that dose. We've also been able to collaborate with home health and infusion companies here at at Clifton campus by providing Lasix at home. Our patients are able to tell the nurses, I really think I need my IV Lasix. They get their dose at home. Sometimes the nurses will contact us and tell us, look, this patient is starting to look volume overloaded, and we can tell them, go ahead and give the Lasix. The other thing we provided was a strict guideline for increasing diuretic dosing at home. So when home health nurses go to see the patient, if a patient is starting to look a little bit decompensated, instead of their first instinct to be to send the patient to the emergency room, they now have criteria they can follow to optimize the patient's diuretics at home and then contact us if that doesn't seem to be working. We have also hired an advanced heart failure specific palliative care physician here at Clifton campus. Dr. Jabeen Thaj has been very helpful in helping us with a lot of our end-stage heart failure patients as well as transplant and LVAD patients. And so we're very thankful for her services to our group. Now, these options for giving outpatient Lasix have currently been restricted to heart failure, but I would like to start expanding them possibly to cardiology. We have to figure out an exact mechanism of doing that. And as soon as that happens, we should be able to provide this as a service first to all of cardiology so that you all will have the ability to send your patients down for IV Lasix if you feel that's necessary as well. Changes we've made throughout the system is we've been working really closely, as I just stated, with our home health and infusion companies. The preferred providers for Emory are visiting nurse health, specialists, and Quorum, VNHS and Quorum. And so they have been working with us pretty strongly in trying to make sure we improve outcomes for all of these heart failure patients and reduce our readmission rates. Again, we've also created a hospital medicine discharge heart failure clinic. So for patients that are admitted to the HMS service, we know that patients that are admitted to cardiology service are going to get cardiology follow-up. We have no doubt with that. But those that are admitted to hospital medicine service, it really wasn't clear whether or not they were getting follow-up, forget about timely manner, if they were getting a follow-up at all after their heart failure admission. So we've created a hospital medicine discharge heart failure clinic. So patients discharged from their service can be seen within the 7-day window within this discharge clinic, again, to make sure they don't fall through the gap. That is going to be the bridge to get them to their physician visit. We've increased the amount of education we provide the nurses, not only on the cardiology floor, but the medicine floors, where many of these heart failure patients reside during their hospitalization, in an effort to continue to improve the education these nurses can provide to their patients. We've also recently collaborated with Bud Terrace. A big issue with our patients with inotropes, despite the fact that they may be ambulatory, so ambulatory ill, they were not able to go to a subacute rehab to really build their strength. Now, Bud Terrace will actually be accepting our patients on inotropes so they don't have to go home and become more and more debilitated. As we all know, home PT really isn't the same as subacute rehab. And so this can provide patients hopefully better outcomes because they can get the actual rehab that they need. We've also updated core measures. So when all of you, probably more the fellows, less the attendings, fill out the heart failure core measures discharge form at the time of discharge, soon you will see that this form has changed. It will actually be much more comprehensive with regards to making sure that our patients are getting guideline-directed medical therapy. Despite the fact that this doesn't reduce readmissions, it's still important that we provide quality care to all of our patients. Sometimes things don't get missed. So this is an attempt at us making sure we dot our I's and cross our T's so that patients get the appropriate therapy. And if they're not, there's a reason why, and that's documented. Also, we've improved our palliative care services throughout the system. I believe now we have outpatient palliative care services 5 days a week at Clifton campus and Midtown, as well as palliative care services at all 4 hospitals inpatient-wise. And so this is really important, especially for our heart failure patients who definitely require some outpatient as well as inpatient management. So with all of this work that we've done, have we seen any progress? Well, hopefully I wouldn't be talking to you if we hadn't. So we started this project in the middle of FY 2016. And so from FY 2015, there was already a little bit of reduction in readmission rate. And as you can see, in fiscal year 2017, we've actually reduced those readmissions even further. So we're about 14.35%. Now, in full disclosure, FY 2017 only accounts for September and October. So it's only 2 months, but my hope is that this trend will continue. We haven't really factored in our problem months of November, December, January just yet, but I'm going to be optimistic that this will be the continued trend. How does each hospital fare? For the most part, all of our hospitals are doing a great job. St. Joseph's is actually the champion with regards to these reduced readmissions. As of fiscal year 2017, so September and October, their readmission rates are down to 10%, which is pretty impressive. The next is Midtown, who has a readmission rate of 11.2%. Johns Creek is faring in at 14.3%. Clifton campus is a little bit of the problem child. Unfortunately, our readmission rates do continue to go up. But again, we are a referral center for heart transplantation and a lot of advanced therapies. I'd like to say we see a lot of very ill patients, some of who don't qualify for advanced therapies. So they do have a lot of readmission rates for that reason. I have been diving a little bit deeper into who are most of our readmissions as of September and October. And I can't blame hospital medicine anymore. Cardiology really is bearing the largest burden of these readmissions. And so we just need to figure out exactly what we can do to try to improve upon that on this campus. So where do we go from here? What are some future strategies that we can employ? Well, as much as I'd like to say again, heart failure is a terminal illness. And like any terminal illness, sometimes I feel like maybe the term heart failure doesn't bear the same burden on patients as maybe if we called it heart cancer. And if we're going to call it heart cancer, we should try to treat it that way. Again, it's a terminal illness with a shortened life expectancy associated with it. So I looked at the Winship Cancer website to see what they provide their patients. And they provide an amazing amount of supportive care to help their patients not only live with their disease process, but try and manage it. They have supportive care services, psychiatric services, wellness services, nutrition services, social services, rehab services, nurse navigators, all to try and help the patients deal with what they're going through and help them, not only them, their family. These are diseases that affect not the individual, but the entire family. Help the entire family go through this process with them and understand what all of this means for their life expectancy. So I would like to see us turn heart failure into heart success by creating something very similar to this. having designated hospital and clinic space so we can provide these sorts of services for our patients with social workers that are dedicated to heart failure certified nurses throughout the floor taking care of these patients and in the clinics, heart failure navigators to help these patients so they don't feel like they're alone in trying to deal with this disease burden. They have someone that they can go to that can assist them with their management if they have questions of any sort. Social workers, pharmacists, again, supportive and palliative care, all to provide support for these patients through this difficult time for them. A concept that I find very interesting that typically comes out of a lot of single-payer systems, such as England and Canada, is this concept of hospital at home. So Johns Hopkins, our friends to the north, looked at utilizing this sort of service within their community. So what this does is it provides acute care at home. So this would be us having a physician go into these patient homes, provide diuretic dosing, maybe getting labs that were assessed daily, and really providing the hospital care at the home setting. And this really does come down to much better outcomes for patients overall. It reduces complications, obviously. Patients are at home. There aren't all these hospital-associated infections or complications that are associated with that. Costs are obviously cut by almost or more than 30% even, mostly because of shorter length of stay. And for the acute care at home, what that translates to is the amount of time these patients receive acute care. So the amount of time these physicians are going into the home. 3 days versus 5 days of patients being in the hospital. So really less amount of time that these patients require acute care. It also goes down to lower cost. Biggest issue here that people or physicians have is patient safety by using this sort of method and what sort of legal risk physicians are going to take on if they do this. Also, there is no payer for this within the United States healthcare system. Medicare won't even cover this. So it's not something that is currently reimbursed in our healthcare system. So it's, I think, something we should look at in the future. I think a lot of these patients would do better being managed at home. We just have to convince government to try and pay for it, or somebody to try and pay for it. So where do we go from here? You know, there's this concept of bundle payments coming down where 90-day readmissions for heart failure might even be scrutinized, and you know, cumulative hospital stay might even be looked at. So that means, you know, currently we can sometimes discharge patients from the ER. We can use the CDU if we think it's going to be a less than 48-hour admission. But unfortunately, all of that is going to be added up and considered when looking at reimbursements for hospitals. Capitation is another concept that is coming down the road, and Emory Healthcare has already gotten involved with this. The Emory Healthcare Network Advantage Program uses this Care More model where patients that have this certain insurance plan, that's Emory Advantage Healthcare Plan, are then followed in the Emory primary care clinics. And there are certain disease processes that they follow very carefully, one of which is heart failure. So they manage these patients very carefully in the outpatient setting. However, if one of them comes into the hospital decompensated, they actually have their own hospitalists that manage these patients in order to ensure the patients get the quality of care that meets their standards. So these patients are cared for by their primary care doctors, by their in-hospital physicians, and then make sure that the patient, again, is followed up in the appropriate time frame with the appropriate amount of information relayed to the follow-up physician from that admission so that these patients receive the kind of care they're supposed to get, so we don't, again, fall through that gap. It's interesting to me because I feel like it models partly what we do in our clinics. We see our patients in clinic, we see them in the hospital, we know everything that's gone on with them, and then we again follow them in our own clinic. So it's kind of the model we use in heart failure, and I'm sure you all use in cardiology as well. And it reminds me of a time maybe 20 years ago when primary care doctors took care of their patients, whether it be on the outpatient side or the inpatient side. So I find this concept very interesting. To me, it sounds like it's one that I think kind of meets all the criteria for trying to reduce readmissions. But then again, you know, with everything that's changing in our current climate, I don't know what's going to happen and where this is all going to go. This all might be out the window. So I have no idea how things are going to change with healthcare in this country. So in conclusion, we've taken extensive steps to reduce length of stay, and we've had some successes with that as well. We've also done a lot of work on trying to reduce readmissions. I think we could take it even further. There's a possibility of us starting to see all heart failure patients within the Emory hospital system as consult service to make sure that these patients get the appropriate care that they need, that they're being diuresed appropriately, that their comorbid conditions are all managed. But we'll have to see where this all goes. So far, our changes have proven to be promising. With that, I think I'll stop, and if there's any questions.
That's great, Divya. I know when the VAP initiative was started, there were a number of areas that were looked at, and heart failure was really one of the major ones that was different from what orthopedics was using for spine surgery, that type of thing. This was something that had a very diverse population of patients at multiple hospitals, I think as you went through this, you did a fantastic job and in your talk pointed out the differences in the different hospitals and how one product or size may not fit all. I'd like for you just to share with us sort of what you learned in going through the VAP process, Emory's ability to provide you with data, what it was like working within the teams. You got quite a bit of buy-in, but just what did you learn going through this system approach?
So I definitely found that it is amazing the kind of data that we have at our fingertips through the data warehouse. I am able to find out in a month how many readmissions we've had at each hospital, what the ages of the patients are, what are their insurance types, did they get a palliative care consult, are order sets being used. So it really helps us deduce where we can try and make an impact in improving quality of care for our patients. And it's been amazing to see, number one, the amount of interest throughout our system in trying to improve on heart failure management. There are a lot of dedicated people that are involved in our system. Sometimes make me feel bad. They're so involved with heart failure. I should be that good. But they really are dedicated to doing this. And we have people coming from Johns Creek, where you guys, I never knew how far that was until I had to go to a meeting there. So we have people coming from all the way out there to come and meet us for weekly meetings on trying to improve outcomes. And so the dedication to this project has been substantial. And I was quite impressed with how much everyone wanted to be involved in improving care for our patients.
Another thing I like mentioning going through this process, the American Heart Association has the Get With The Guidelines program, and through this we actually chose not to participate directly in that. Do you want to comment on that?
Yeah, sure. So this was actually a very difficult decision. It took months to make. I think, are we the only system in Atlanta that's not a part of it? We are. So we are the rebel child. And a big part of that was because it was going to cost us over $300,000 to be involved with that project. And our thought was our gains were going to be minimal because we can actually gather that data and assess it for ourselves. And that's a part of our change to those heart failure core discharge measures, is to be able to take that data and assess it for ourselves, make sure we're providing that quality of care. And then our thought is we can take that money and use it towards getting a heart failure educator / navigator, heart failure dedicated social workers, resources that we really do need in trying to improve things for our patients. So it was just a better use of funds, especially when we thought we could obtain and assess this data ourselves. Yes, sir.
Divya, very impressive work. A couple of questions come up. One of the things that I see that impresses me is the inadequate use of diuretics. That this fear of diuretics throwing somebody into renal failure and seems to be an overriding factor. My question is also your 7-day return rate and your 2.5 times diuretic dose, is there data to support that, or are those just numbers pulled out of the air?
So the data for the 2.5 times for the diuretic dose comes from the dose trial. So that was the trial where I showed the data. They looked at low dose, or patients getting their home dose of diuretic in IV form, versus high dose, which is 2.5 times their home dose of diuretic in IV form. And there were significant improvements in dyspnea as well as volume loss during a 72-hour period. That was the period of the study. But the downside was there was a slight increase in creatinine during that hospitalization. However, those increases in creatinine were transient and improved over 60 to 90-day follow-up. When it comes to the 7-day, I'll tell you previously guidelines used to say 14 days. And I don't know if there was actual studies that were involved with regards to using 7-day, to be very honest. I'm not clear on that. But all the guidelines at this point now state, whether it be ACC, AHA, or HFSA, those are all the, Heart Failure Society, they all state 7-day follow-up is a big component of trying to make sure we stay out of the hospital. Some will actually even say 5 to 7 days. And I'm not quite clear if there's research regarding that, to be honest. Yes, sir.
Divya, that was outstanding.
Thank you.
And it's wonderful to see what we're doing here on a system level. A couple of questions and points. One is you pointed out the 7-day follow-up visit and the importance of social determinants of health. Is there anything we're doing to find those patients who don't show up for their 7-day visits? Or because the challenges are, I think you can probably predict the people who are higher risk for not showing up. They're having social challenges, or they're from outside healthcare systems, and so anything we're doing there. The other question or point is, you mentioned about once you get to the ER with heart failure, you're going to be admitted, high likelihood, and so having ER pathways. But is there any messaging we're giving to our nursing teams and having a nurse support for heart failure patients? Because if they call our cardiology regular clinics or primary care, and they're going to say, go to the ER. And then the last one is Winship is doing a wonderful job with these comprehensive supportive services. It's really amazing. How are they paying for that? Any idea who pays for that through Winship? Because we're in dire need. So 3 questions, sorry.
I'm trying to remember now. So the first one was, right.
Okay, who doesn't show up? Anything you do to follow up on those people? How do you chase them down?
That's something we're trying to work on. So currently there's a bit of a disconnect between outpatient and inpatient data services. And I wish my data friends were here. Matthew Kumaraswamy, who's a big part of the VAT program, is a master when it comes to all of this data stuff. He states right now there's a big disconnect between inpatient and outpatient. So he's working to try and bridge that gap so we can create this connection and try to find out who these patients are that aren't following up and why that's happening. Right now, unfortunately, we're not able to do that, but he tells me that hopefully that should be happening soon so that we can better access those patients and get them into the hospital. With regards to the nursing staff, I'll be honest, in our heart failure clinics, obviously our nurses are very good at helping with that. And if you could, I would love, and part of this is so I can get input from all of you. I think that's a great idea. Help me understand, maybe we can create education services for the cardiology nurses, from our nurses, to try and help improve on that. So the first instinct is it to send the patient to the emergency room. With regards to primary care, I'm actually scheduled to meet with, his name is Dr. Ted
Johnson.
Thank you. With primary care to try and work on improving things from that perspective. But maybe we can come up with some education sessions for general cardiology nursing so that we can improve their input to the patient. And then the last one, you have to remind me, I don't know how they're paying for these services. And so this is something that I think is the next step, the next frontier, my future strategies, if you will, so that we can figure out how we can then get these for our patients. I agree 100%. Thank you. Thank you. Thank you, everybody. Thank you for coming.
The preceding program is copyrighted by Emory University.